All
Awesome.
right. So anyway, I'm Jeff Weber. I'm a medical oncologist. I'm the deputy director here at the Perlmutter Cancer Center. And I've been, let's just say, in the melanoma business for a long time. And I've seen immunotherapy evolve from sort of a hopeless scenario to truly mainstream. I've just been writing an article, and I believe there are 20 approved indications for drugs like Pembro, another 15 for nivolumab. It's really been an amazing time. So we're going to talk about adjuvant therapy for melanoma. So let's see if, there we go. Those are my disclosures. If anybody has questions, I'm glad to talk about them after this. So the question is, what's adjuvant therapy? The word adjuvant, by the way, in the English language has multiple meanings. But in this sense, we use the word to mean added to, that is, some therapy given after surgery. And the idea is that if you treat a tumor where there are very few cells circulating in the body that are trying to take root and grow, it's easier to treat them when there's fewer of them, when they haven't taken root into the normal tissues and created this immune suppressive environment, rather than treat them when there are a few cells rather than many. And it means what's going to happen is you're going to treat more patients than those who actually would benefit, since some patients are going to be cured anyway with surgery. And depending on the risk of recurrence, you could have patients with a 20% risk of recurrence, which means 80% of them are cured no matter what. Or you could have people with an 80% risk of it coming back, which means almost all of them would potentially benefit if you gave them some further therapy. So let's say you wanted to treat the high-risk group. So high risk means, to me, 50% risk of relapse at 5 years. If somebody told me I had a 50% risk of my tumor coming back at 5 years, I'd say that's pretty darn high. And let's say the adjuvant therapy reduces the risk of the tumor returning, which we call recurrence, by half. That's pretty good. I mean, to me, that's pretty good. So you would need to treat 4 patients to avoid 1 recurrence, right? Because half of them are cured no matter what. And of the remaining half avoid recurrence. So half of half is a quarter, which means you treat 4 to benefit 1. Problem is that gets a bit expensive, because if you guys knew exactly how much a year of adjuvant therapy costs, it ain't cheap. It could be over $100,000. And the question is, it's sort of a pharmacoeconomic or social issue. What ratio would you all accept to generate benefit? So to me, it's always this balancing act. And the balancing is, on the left side, you have the side effects, because the drugs are not without side effects. And it's got a cost. I just told you, it could be $100,000 or more. It could be a couple of $100,000, depending on how it's done, to give a year of adjuvant therapy. On the other hand, the benefit is it prevents recurrence, and that's pretty good. And it probably prolongs survival. And I'm not sure I have a good slide to show it, but I can reassure you, if you do the calculations, compared to giving no therapy, almost all of our current adjuvant therapies prolong survival, and that's the name of the game. So let's just run through some of the recent trials. And again, this is a typical slide. It shows in the area that's outlined in, well, I guess it's kind of brown. It shows that if you take patients, and this is a trial, it has a name, it's called Keynote 716. All of the trials with pembrolizumab are called Keynote trials. Don't ask me why, that's just the way they are. This was a trial of patients whose melanoma was relatively thick. That is, it was more than 2 millimeters, up to any number of millimeters in the skin, but it had not gotten to the lymph nodes. That's what we call stage 2, stage 2B, 2C. You either got pembrolizumab for a year or you got a placebo. Why a placebo? Because there wasn't a standard of care. In fact, right now, there still isn't a standard of care for those patients. And you give them a year of treatment, you give it every 3 weeks, and you follow them up. And the main endpoint is, did the tumor come back or didn't it? So it's recurrence. And here's the data. They just came out. They just got presented a couple of months ago. This is a graph of recurrence. On the bottom is time. So time goes to the right. And the rate of recurrence, or I should say, the likelihood of not recurring, is up at the top. So if you're at 100%, that means it ain't coming back. If you're at 50%, that means half the patients recurred. As you can see, up to about 18 months, the green curve looks better than the brown curve. The green is if you got pembrolizumab, the brown is if you got nothing. And if you look at something called HR means hazard ratio. Hazard ratio means what's the difference between getting the treatment and not getting the treatment. If the hazard ratio is 0.65, that means you've reduced the risk of it coming back by 35%. That's not bad. So again, since the risk of recurrence is pretty low, since these aren't bad tumors, it's projected to be about a third of the patients would have a recurrence at 5 years. So if the risk of recurrence is cut by a third, the problem is now you need to treat 9 patients to benefit 1, which is a third by a third. So a third times a third is a ninth. So 1 out of 9. So the problem is, what if you relapse, but you could still be cured by surgery? That's a bit of a problem. That means maybe it would be even more patients would need to be treated to benefit 1. So again, the patients in that study had stage 2B and 2C disease, no lymph node involvement. So what if you relapsed in the lymph nodes 2 years later, and then you took out the lymph nodes, or Rich, for example, took out the lymph nodes, and then what if that cured you? So that means you could still relapse and be cured. Whereas if you have advanced melanoma that's in the lymph nodes or the organs, if that relapses, you got big problems. But in these patients, well, maybe if it relapses, you could be cured. So if you do the calculations, you might need to treat 10 or 11 patients to benefit 1. And this is something called a forest plot. By the way, it has nothing to do with trees. The man who invented it, his name was Forrest. It's Forrest. So if you hear about a forest plot, it shows breaking down the different groups of patients. So you see where it says age less than 65, the little black square is to that line. The line means there's no difference. If the black squares are on top of the line, that means there really wasn't any difference in the treatment. And if you look at geographic region, bizarrely, if you're in the US, you didn't see where I put that blue arrow? It doesn't make any sense. The patients who were in the US got almost no benefit. The patients who are outside the US, the black square is to the left of 1. That means you benefited from getting pembrolizumab. And you see those little lines that come out of the square? That's where 95% of the patients are. So if 95% of the patients do not overlap 1, that's a good thing. So it looks like the patients outside the US did great. The patients in the US didn't do so well. And then look up where it says T category, that talks about how thick the tumor is. And see where my blue arrow is on the right, where it says A, makes no sense or makes sense. If you have the thickest melanoma with ulcerations, the black square is right on 1. They didn't really get much benefit. It was the thin melanomas that got the benefit, but those are the ones least likely to recur. So go figure. So this is a bit confusing, and the FDA is going to have quite a time deciding what to do about this trial. Okay, so that's if the risk of recurrence was low. What if the risk of recurrence is higher? So instead of stage 2 patients, what if you have stage 3B, 3C, and 4? Their risk of recurrence is well over 50% at 5 years. So again, the higher the risk, the fewer patients you need to treat to see a difference, because the number of events, an event means a relapse or a recurrence or death, will be higher. So again, keep in mind, the hazard ratio is the ratio of the tumor returning between those who get treated and those who don't. And it turns out that in our case, when you treat the higher risk patients with immunotherapy, the hazard ratio is about 0.5. That means you cut in half the risk of relapse. A hazard ratio of 0.5 is pretty darn good. No one's complaining about that. So here's the trial. Again, similar kind of slide. You take over 900 patients and you randomly allocate them with a flip of the coin. Now it's done by a computer. It's not really a flip of the coin. They either got nivolumab for a year, or in those days, remember, this is back in 2016, you got ipilimumab, the other immunotherapy, which was approved in the US. They each got treated for a year, and then you followed them. And you followed them to see who would recur. And here's the latest data. We've now followed them for 4 years, which is a fair amount of time. And you guys tell me, would you rather be on the green curve of recurrence or on the gray curve? I'd much rather be on the green curve. That's nivolumab. And the gray curve is ipilimumab, which in those days was the standard. So we did better than the standard. And the standard itself, by the way, did prolong survival and recurrence. So you have benefit above and beyond the treatment that itself already had benefit. And if you look at 4 years, things are plateauing. So here on the bottom, we call that the x-axis, that's time. It moves to the right. On the top is recurrence. So 100% means nobody recurred. 0% means everybody recurred. But of course, the curves are somewhere in between. And if you look at 4 years, a little less than half the patients have recurred. Now, I happen to know at 5 years, that's about 50-50. So you figure the median time to recur or return of the tumor is about 5 years. That beats the heck out of doing nothing, because with nothing, it's about 30%. To me, 50% is a lot better than 30%. And again, what about survival, right? Isn't that the most important thing? It's not whether the tumor comes back, but whether you're going to live or die. To me, if I were a patient, that's what I'd think about. So in the next slide, you see the survival curves for those who got nivolumab, which is the PD-1 antibody, versus those who got ipilimumab, which is that antibody, it's the old one against CTLA-4. Turns out there ain't any difference. How could that be? The recurrence rate was clearly better for the nivolumab versus the ipilimumab. And the answer is crossover. What's a crossover? That means if you got A and it didn't work, you can get B. If you got B and it didn't work, you could get A. If the sequence doesn't matter, then survival becomes meaningless, because everybody at the end of the day, if the tumor returns, can get the same treatment. So here's the survival curve. I think you'd all agree there ain't a difference. That gray curve absolutely overlaps the green curve. Now, at the end, it breaks apart a little bit, but if you look at the hazard ratio, it's pretty close to 1. A hazard ratio of 1 means there's no difference. So what this reflects is the crossover. Now, frankly, we don't use ipilimumab anymore. Everybody gets nivolumab, but it just says that's a pretty good survival. At 4 years, it's 78% for nivolumab. At 5 years, I'll give you the tip off. It's probably about a quarter or 3/4, so 75%. And it looks like it plateaus. So that means that you've cured 3/4 of the patients. Now, keep in mind, some of them would be cured anyway, but not that many of them. What you've done is you, instead of having a 50% survival, you now will have a 75% survival, right? So that means of the 50% who would have died, half of them, or 25%, are now alive. That's a big deal. That's a hazard ratio of 0.5. Now, there's another similar antibody. It's called pembrolizumab. And if you look, it's the similar kind of slide. You either got 1,000 patients, and there was a flip of the coin, and from 1 to 1, that is, for everyone that got pembrolizumab for a year, 1 got placebo. This was done in Europe, where there was no standard of care. We already had ipilimumab and nivolumab. In Europe, they didn't have either for quite a while. And they got followed for recurrence. And if you look in the yellow, you were guaranteed, if you recurred after being on the placebo, you could guarantee to get pembrolizumab. So the person who was the principal investigator said, well, this is a way of deciding, should we treat everybody, where we're treating 4 patients to benefit 1, or should we just wait and only treat the patients who recur once they metastasize? Well, if I were the patient, I'd say, the hell with that. I want to avoid metastasis, but it's not a crazy thought. My personal feeling when this started out was that's a bad idea. And I would have bet good money. In fact, the person who's the principal investigator is a friend of mine. I bet him $20 that he was dead wrong. And I think I'll show you in a minute he was wrong, although he won't admit it. If you look at the left-hand curve, in blue, that's pembrolizumab. In red, that's placebo. You obviously do a lot better in terms of recurrence. The absolute difference is 19%. That's a big deal. And if you look at that thing on the right, that's distant metastasis-free survival. That is, it's not survival, it's surviving without a metastasis that's distant from the primary. That's also pretty good. I'd much rather be on that blue curve than the red curve. So like nivolumab, pembrolizumab works. It prevents the return of the tumor. The patients do well. And this time, instead of ipilimumab as the control, it's no treatment. So there's a bigger difference, no surprise. But this is what happens if you recur on the placebo arm and then get pembrolizumab. At 2.5 years or 3 years, only 1/3 of the patients are free of progression. So think about this. That means that if you look back, it looks like about 1/3 of the patients are going to relapse over time. Maybe a little more, but not much more. because these, by the way, are better outcome patients than in the other slide that I showed you for the nivolumab trial. So let's say, for the sake of argument, a third of the patients are destined to relapse if you get pembrolizumab as adjuvant therapy. Here, if you don't get pembrolizumab as adjuvant therapy and you just get a placebo, 2/3 of them are going to progress with metastatic disease. That ain't a bargain. And to me, that says it didn't work. You'd much rather treat 4 to benefit 1, because if you relapse and you're not getting treated, you're not going to do well. Whereas I'd rather be at a 1/3 rate of relapse rather than at a 2/3 rate of progressing. So you make your decision, you do the math. I don't think you benefit by waiting. I think you benefit by treating. So would you rather be treated with adjuvant pembrolizumab and have 4 patients to benefit 1? Or would you rather wait, get no treatment, and then relapse and then get pembro? And there you're treating 2 patients to benefit 1. That's cheaper, right? But here's the issue. 2/3 of the patients will remain free of disease at 5 years if you give adjuvant therapy. In the placebo group of those who recurred and got pembrolizumab, only 1/3 were free of progression at 3 years. Which group would you rather be in? I'd rather get adjuvant therapy, but you guys make your decision. Then came the next adjuvant study, and this was a study of ipilimumab with nivolumab, which works well in metastatic disease, versus nivolumab alone. And again, the slide should be familiar to you. There's a flip of the coin. They were 1-to-1, and now you got 1,900 patients, because both of them are going to work probably. They're both active regimens, the combo versus the single drug. And we figured, well, the combo worked better in metastatic disease. It would work better to prevent recurrence. Well, we were wrong. It didn't work. The combo is here in brown. The single drug is in green. The combo is not any better than the single drug. And the recurrence-free survival at 24 months looks just like the prior slide that I showed you, where about 1/3 of the patients have relapsed by 2 years. At the end of the day, it's going to be about 50% at 5 years, and that'll be a plateau. It was a bust. It didn't work. Why did it fail? The reason why it failed is the regimen got changed. We gave the IPI at a lower dose and gave it every 6 weeks instead of every 3 weeks based on lung cancer data. And the sponsor, and we're not going to talk about individuals here, decided they wanted to reduce the toxicity. And now that's a big deal. And the problem is the increment that was provided by the IPI at 1 milligram per kilogram every 6 weeks wasn't enough to see a difference. In my opinion, and I was against it, if you gave 1 mg per kilogram every 3 weeks, it might have worked. But the irony is giving the ipilimumab every 6 weeks didn't reduce the side effects. It was 1/3 of the patients had severe side effects. Giving it every 6 weeks, 1/3 every 3 weeks. So the whole thing was a complete bust. And somebody wasted $50 million on doing a trial that was negative. Okay, finally, what about targeted therapy? We heard that you can use these BRAF drugs to hit this mutated BRAF present in about 40-50% of melanomas. Those drugs, we call them the BRAF MEK drugs. They're 2 at a time. They're oral drugs. They probably wouldn't have the potential for long-lasting side effects, which occur in a small number of immunotherapy patients. Problem is the overall side effects are pretty high. Interestingly, in metastatic melanoma, targeted therapy does not have the long-term plateau of survival seen with immunotherapy. But a lot of people said, nah, it's not going to be as beneficial as adjuvant immunotherapy. The funny thing is, they were wrong. This is the one trial done of adjuvant targeted therapy. It's called COMBI-AD. It was finished years ago. And you got a year of dabrafenib and trametinib in a randomized trial where there was, again, a flip of the coin, and there were like 900 some odd patients. You either got pills, the dabrafenib, trametinib, for a year versus placebo, because in these days there was no therapy that was approved. And look at the long-term relapse-free survival. It's amazing. There's a plateau exactly where you would predict it would be with nivolumab or pembrolizumab. This is 5 years, and I think you'd agree there's a plateau. And now you have a placebo, and this tells you what happens when you get a placebo. If you just get a placebo and don't get treated, only 1/3 of the patients are free of relapse at 5 years. Well, close to 1/3, it's 36%. So that's pretty impressive. And the predictions that the targeted therapy wouldn't work, well, ain't true. Targeted therapy looks just as good as immunotherapy. So now we got 2 ways of treating our patients. There is a plateau on the curve. And if you don't recur by year 5, you're probably cured. And again, it's different from the curve in metastatic disease where many of the patients progress. So, who do you treat with targeted therapy and who do you treat with immunotherapy? That's a tough one. And you're trading off total toxicity versus long-term toxicity, and it's very hard to know. So, my conclusions: adjuvant therapy for melanoma is a balancing act between the risk of toxicity and the cost versus the benefit defined as reducing recurrence and prolonging survival. Adjuvant PD-1 antibodies like Nivo and Pembro clearly reduce the risk of recurrence. In my opinion, and based on lots of indirect data, they prolong survival. Adjuvant targeted therapy with dabrafenib and trametinib also reduces the risk of recurrence. Amazingly, it looks like it's about exactly the same. Both drugs have a plateau at 5 years, and I think that we're curing our patients. But what's the price of adjuvant therapy? I don't mean the monetary price, but it is expensive. There's toxicity. And the way to get around the fact that you're treating 4 to benefit 1 is you have to do a better job of predicting who doesn't need it, who's going to be cured no matter what. And that is when you need to define your biomarkers that you would test before therapy. And if you had a test in the blood that said, oh, no, this patient's never going to relapse, you can pat them on the back and say, yeah, you're not going to relapse. You don't need any further therapy. Whereas the ones who need it will be the ones who get it. Anyway, thank you for your attention. And I guess I will stop sharing. And I see a lot of questions.